So I'm moving to the next part of the presentation. So there is a very good publication I really like from Sweden. Yeah, Swedish patients, but yeah. I mean, you work really close to each other, and yeah. I need to be very careful. Yeah. This kind of work from Finland with Swedish patients. Almost 14,000 patients with amphetamine use disorder, okay? And they started from July 2006 to December 2018. And they have been followed for almost 4 years, okay? The mean age of these patients are 35 years old, okay? So you have a population of 14,000 patients, 35 years old, followed for almost 4 years. And the question is, what are the predictors of death and hospitalization in these patients? Okay? Just start thinking about, and what is your estimate in terms of how many of these people have died after 4 years of follow-up, or in the process of 4 years of follow-up? How many of them, these 14,000 people, how many of them died in 4 years? And they are 35 years old on average. So we are talking about pretty young population, right? And we are talking about Sweden. So we are not talking about the US or places that we have not very good kind of medical care. So the places that they have a really state-of-the-art public health system. What is the estimate? What is the percent of those who die? Any estimate? And what is the percent of those who are being hospitalized? Rough estimate of those who are being hospitalized. Just give a number. I mean, no, they are community-based settings. So 14,000 community-based, probably reasonably healthy, but with amphetamine use disorder, 35 years old. How many of them are going to be hospitalized in 4 years, over the process of 4 years? So 82% of them were hospitalized, and 9.5% died in 4 years, which is very high, right? It's beyond the thing that you might kind of imagine, that 10% of the population would die in 4 years. And this is showing you the significance of that. And then what are the predictors in terms of the medications? So I'm gonna give you a list of medication. Of course, these people have been on many different medications, right? What are the medications that could predict whether they are going to die or being hospitalized? First of all, go to the down. Benzodiazepine would increase the risk significantly for hospitalization or death, okay? Benzodiazepine. Things that would reduce the risk, lower risk of hospitalization is, first of all, medications, SUD medications, and also ADHD medications, interestingly. So you see that ADHD medications overall, those who have received ADHD medication, they have a lower risk of death or hospitalization. And then SUD medications in total, I mean, acamprosate, buprenorphine, disulfiram, I mean, those things that they have, they increase the chance that they live longer. So the medication that we are prescribing is very important. And the way that we prescribe them and how we optimize them, they are very important factors in what we are doing. And actually, the substance use disorder medications are working, even when we are talking about people who have amphetamine use disorder. But of course, this is not just pure amphetamine use disorder. They always have something else, right? So there are always other combinations. There are other interesting things that I still think that we need to think about. Things like antipsychotics, antidepressants, they increase the risk. So we can further think about how those comorbidities, is it because the antidepressants, or it's just because those who have been depressed and they have been receiving antidepressants for that, I mean, those comorbidities, how they contribute to the higher risk for death. And the way that we are prescribing those medications is about our molecular understanding, how things are working together, how those things are related to the way that amphetamines are working in the brain. So let's discuss a little bit about molecular understanding about what we have for amphetamines, and we will have further discussion with the specific session that Yona is going to discuss about kind of amphetamine use disorder and stimulant use disorder, the treatments for that. But technically, that molecular understanding and the kind of neuroscience that we have for stimulant use disorder, we know that dopamine is the central molecule, right? So dopamine is the core for stimulants. And dopamine is important in a specific pathway that is called mesolimbic mesocortical. And it starts from an area in the brain we call VTA, and the neurons go from VTA to an area that we call nucleus accumbens or mesolimbic area, and then to the cortex. So we have mesolimbic and mesocortical pathways. And at the end of the neurons, when they have their kind of axonal terminals, in their axonal terminals, at the end of those arrows, they release dopamine into the synaptic space, right? And you need to know about few molecules here. First of all, the blue dots are dopamine, right? So we have dopamine receptors on the postsynaptic terminal, and we have dopamine transporters that bring back dopamine. And also we have a specific molecule here that is called VMAT or VMAT2 or vesicular monoamine transporter 2. Now we have a new generation of medications targeting VMAT. Anybody remembers what are those medications? Medications that are targeting VMAT. Medications were, Medications that are targeting VMAT. Medications for tardive dyskinesia. Deutetrabenazine, that specific new category of medications for tardive dyskinesia, they are targeting VMAT. They are targeting VMAT. And that is the reason that they change the level of dopamine in the circuits to change tardive dyskinesia. I'm not going to discuss about that, but these three molecules are important for us. How they are important? So when we talk about dopamine and dopamine neurons and the way that dopamines is being released on those circuits, so we discussed about ventral tegmental area, nucleus accumbens, and prefrontal cortex, and dopamine which is being released to nucleus accumbens, also to cortex from ventral tegmental area, and also the prefrontal cortex that has glutamatergic input to dopamine to release dopamine. And also GABA system would also inhibit dopaminergic pathway, and also opioidergic system that would interact with these sort of pathways. So we have dopamine as the core, but always GABA involves, glutamate is involved, opioid system is involved, and then norepinephrine also is playing a role here. So those neurotransmitters are interacting with each other. So it is not only dopamine, we always have other things that are playing around and make things complex, okay? And then different substances, including stimulants, they are interacting in these sort of circuits in the brain. But the main stimulants that we have, cocaine and amphetamines or methamphetamine, how they are different from each other. Cocaine, plant-based, amphetamine is synthetic, right? Which one is longer acting, cocaine or amphetamines or methamphetamine? Meth is longer acting. So if we see meth takes up to 90 minutes to clear from the brain, cocaine is just few minutes. So cocaine is definitely faster acting compared, these are the minutes, the x-axis is just the minutes, how long does it take? And they change the brain and how the brain is structured or function. This is what we have. We know that methamphetamine users, they have the level of dopamine receptors and dopamine transporters that they have in their kind of a striatum is just changing, and how a period of abstinence could help people to recover from those structural changes. So these are the things that you have heard about meth and methamphetamine use. But let's just go to the further technical details. So when we talk about cocaine, we know that cocaine has two characteristics. One characteristic is a dopaminergic characteristic, and the other is a norepinephrine. So it has two arms, dopaminergic arm and norepinephrine arm, right? But what is the difference between cocaine and amphetamine? What else amphetamine has that cocaine does not have? What feature that amphetamine provides that makes things a little bit more complex compared to cocaine? What is the extra characteristic that amphetamines have? That is an extra receptor for VMAT. So amphetamines can also attach to VMAT. Why it is important? Let me just go back to figure that I showed you before. So when you have amphetamine, because it can attach to VMAT, it can deplete synaptic vesicles and bring all the dopamine from the synaptic vesicle into axonal terminal. And also the dopamine transporters would just help to release them inside the terminal. So there would be lots of dopamine in the terminal, but there would be also lots of dopamine on the axonal terminal. And why it is important? When you have too much dopamine at the end there, dopamine starts to react to each other and do what we call oxidative stress. And they start to develop what we call free radicals and do lots of oxidation there. And then it makes lots of oxidative stress and neurotoxicity. So that extra dopamine can basically kill neurons or disrupt the axonal terminals. And when you have that, those who work with people with amphetamine use, you know that if you check their inflammation biomarker, many of them, they have higher inflammatory biomarkers. If you check their CRP is kind of usually higher than others. And interestingly, if they start to be absent or reduce their amphetamine use, you can even track in terms of the level of inflammation is going down. And sometimes in my clinical practice, I use inflammatory biomarkers. And sometimes even before starting to discuss about reducing their amphetamine use, they see how it is changing over time. And then you have lower level of inflammation, which is an interesting kind of experience in the clinical side. And meanwhile, there are ideas in terms of how we can reduce that level of inflammation. What are the medications that potentially can be used to reduce that level of inflammation and could be helpful, even sort of in a harm reduction perspective? We have a specific book chapter about that we have a textbook on neuroscience for addiction medicine, and we have a specific chapter. And the full text is available on the QR code. So those who have the slides, they can just find the full text of that sort of chapter if you want to go to the details. But just going back and look into the kind of what we have with further details about ADHD, as we have been discussing about Mr. Z, and people who are using amphetamine, and how these things could be interacting with each other, and what are the potential implications of that. So we know that those who have ADHD, one of the biomarkers of having ADHD is we have a reduction in a way that the norepinephrine system and dopamine system is working. And when we have reduction in that sort of function, the prefrontal cortex function is just lower than normal. If we want to optimize that, we need to increase that to be able to increase the PFC output or PFC function. And PFC function is important for your attention, control, all those aspects that we have disruption in people with ADHD. So with medication, we try to optimize that sort of challenge. And interestingly, people can have different levels about how to optimize that. Specifically, medications like Ritalin, they can have impact on that specific pathway. But interestingly, when you go to details, people think about kind of how cocaine and Ritalin, they have some similarities in terms of this, but there are some major differences in terms of how they are being designed. So methylphenidate is a sort of a pure dopaminergic norepinephrine kind of compound compared to cocaine that has some other characteristics, including serotonergic features. The other feature of cocaine is just cocaine goes like this, but when we have methylphenidate, it's just a different mode of action. Meanwhile, we have things like Adderall or mixed amphetamine salts. This is kind of the routine thing that we are using in the US for ADHD treatment. I can imagine it's not being approved here in Europe, I think, to my best knowledge, for ADHD. So you do not use amphetamines for ADHD here in Europe or those. I mean, but that is something that we prescribe pretty frequently in the US for ADHD. But it has those features I told you. So it has some VMAT characteristic, which can be, if they are being abused, there is a risk. But we do, I mean, the way that we are using that in an extended release is just over the time. It's just not like this. It's just over time to avoid that sort of accumulation of dopamine and the toxicity that it could make. So And then we can have them some like a methylphenidate extended release in a way that they take time over the time, slowly releasing that to be able not to get to that peak. So some clinical case scenarios in few minutes. And then I will stop here, we will go to alcohol, and then we will be back for some further discussions. How much evidence that we have to use ADHD medications for those who have amphetamine use disorder or cocaine use disorder? This is another study from Sweden that they did extended release methylphenidate for people with amphetamine use disorder. And they showed that there is a significant reduction in ADHD symptoms and also significant negative urine drug tests in those who received methylphenidate. One major issue is just the methylphenidate is in 100 up to 180 milligram. So it is a pretty high dose of methylphenidate. So it is not the traditional kind of ADHD med that we use. It's a higher dose of methylphenidate. But they show that there is a significant reduction even in urine drug test. The other study, this is from the US, from Francis Levin and John Grabowski. So they have done, this one is extended release amphetamine salt in ADHD with cocaine use disorder. Sort of similar outcome in terms of 60 milligram, 80 milligram, they reduce ADHD symptoms significantly, as you can imagine, in people who already have amphetamine use disorder. And the interesting part is, this is placebo. This is number of people, I mean, the reduction in cocaine use, as you can see here. And the 80 milligram has the best response, as you can see here. The higher reduction is for the higher dose. And 80 milligram is also above the FDA approved kind of dose that we use. So it seems that the higher dose of methylphenidate for amphetamine user and also amphetamines for cocaine user, there is a kind of level of evidence for that. And also that is kind of the changes with 60 milligram and 80 milligram. And there are some pieces of evidence in other areas, but just I'm going to skip those pieces. And also mentioning that there are some pro-drugs, I mean, least dexamphetamine, that they are even slower release, and they can potentially be helpful. And also some other forms, like Cerdex methylphenidate, that they can also be extended release, that they do not make the peak. And if you avoid the peak and also support ADHD symptoms, there is a significant hope that they could be helpful for stimulant use. But we can definitely go back. I just want to wait for Yona presentation, also presentation in other sections, that they are going to discuss about other aspects. And I'm going to stop here to make sure that we will be able to go back and further discuss about those aspects with other speakers. We will discuss about mirtazepine, bupropion, what people discuss about bupropion and naltrexone, those things, and the guidelines that we have. But yeah, we will be back and hopefully in the discussion further discuss about those things.